I just want to say a massive thank you for so many people attending this morning and a big good morning from Sydney. We're going to do a topic, reptile infectious diseases in clinical practice. So I'm going to do a more like practical side of things. One thing I do want to say, just to make sure you get your CE or your CPD certificate at the end, there is a little quiz, literally takes 2 minutes, just so you can complete that, and then we'll get your, I'll know who's attended, then we can send that CPD certificate through. All right. So massive thank you to MiDOG Animal Diagnostics for sponsoring this webinar, and Harrison's Bird Foods is a long time sponsor of ours as well. So thank you very much, Harrison's Bird Food as well. So just in terms of an outline of what we're going to cover from the practical side today, obviously infectious disease is a massive topic. So I'm going to try and fit as much as I can in this, it's planned to be an hour. So today I thought respiratory disease or respiratory infection, probably quite high of the most frequent diseases that we do see in clinical practice. I'm going to touch on some viruses after this as well. Abscesses, obviously big topic. Infectious coelomitis, and then some skin and shell disease as well. With all of these, we're going to focus on a few pathogens in particular, but I like to do a whole general approach for that. So with all of these, we're also going to cover diagnostic testing, treatment and management, and also prognosis and considerations for each of these. So I don't want these slides to be a list of all these pathogens. However, I do feel like it's very important to point out that for respiratory disease, there's a high prevalence of anaerobic gram-negative bacteria, which is why historically we've been using fluoroquinolones and third-generation cephalosporins for these conditions. They do target gram-negative bacteria very, very well. Special mention to Mycoplasma. Obviously, this is quite a big topic in chelonians. So Microplasma agassizi is probably the most pathogenic and most prevalent in our chelonian world. But there's also others out there, Mycoplasma testudinism, which is less pathogenic than M. agassizi. But there's others out there as well, more for zoological collections rather than clinical practice. But just good to be aware that there's others out there as well. Now, one thing specifically about Mycoplasma, and this occurs with some viruses as well, or most viruses as well, once they're diagnosed as positive, they should be considered lifelong positives as well. So even though you can clear up clinical signs, they can be, or they should be considered lifelong positives. And again, there's other bacteria out there that can cause respiratory infections as well. Not just bacteria, we should also be aware of fungal and viral components as well. Fungal-wise, we think of aspergillosis and Candida as avian fungal infections. However, you can get them in reptiles as well. And then viruses, herpes virus, again, usually chelonian, or chelonians where we see them in, but they can affect all other species as well. And then viruses, more specifically for snakes, and sunshine virus, more specifically Australian pythons. We shouldn't forget parasites. There's some parasites out there. Pentastomids is one of those as well, but we're going to focus more on the bacteria side of things today. So just want to get all those the number of pathogens out the way. I just want to make things as practical as possible. So I'm going to go through some presentations, how they present in practice, and definitely this red foot conjunctivitis. Quite frequently we see these bubbly fluid from the eyes. And then this tortoise, you can see rhinitis, so discharge for the nares as well. Sometimes it's clear. A lot of the time it can be mucopurulent coming out the nose. Some deep set infections can be like streaming out of the nose really, really bad. So we'll come to that later. And then we've got this python here. Sometimes at the choana with these upper respiratory diseases, you get infection in the nasal cavity, and it just, instead of coming out of the nose, it comes into the mouth through the choana, which is just some paired holes at the dorsal aspect of the oral cavity. And then obviously lots of severe diseases, you get these open mouth breathing or dyspnea. So this emerald tree boa is not aggressive. Maybe, but in this situation, it was open mouth breathing due to severe pneumonia. Snakes also quite frequently get this fluid in the mouth. probably most snakes that I see, you see clear fluid or sometimes some mucopurulent infection. And you can get respiratory noise. I'm hoping you can hear this from your side. But if not, you can see there's this extension of the neck. Snakes, they can present with extending the neck as well, just because it's a nice way for them to drain the fluid buildup or discharge, sorry, the fluid buildup in the lungs out of the oral cavity. So in terms of diagnostic testing, most of the diagnostic tests throughout this lecture is probably going to be very, very similar, because I do like a broad spectrum approach. So we're not just going to focus on the actual respiratory disease and the pathogen. I'm sure you're aware, whenever we see these reptiles, a lot of them can be 2 months, 4 months, 6 months already have been sick for. So we want to make sure the whole patient is going to be treated, not just the specific infection that the owner thinks the patient's in for. So we want to do some blood work. CBC and a biochemistry would be standard. And then we can do, so we used our Zoetis machines. We've got the CBC, or sorry, the hematology is more for mammalian blood. However, we've got the vet scan, and that can run avian and reptile blood. And all you need is less than 0.2 of a mil, so even very, very accurate for our smaller species as well. And then imaging, radiographs is usually the go-to and most affordable for owners. So for respiratory disease, definitely lung fields, you can get good images with radiographs. However, probably difficult to identify upper respiratory tract infections unless it's really severe, causing bone damage. So the gold standard now is CT scan. You get much better images, and I'll show you a few of these later as well. And then we've got endoscopy. Huge advantage of that is you're not just going to get black and grays, you're going to get color visualization, and you get the option to take biopsies, take some samples as well. So I generally do radiographs or CT, and then hopefully be able to get like some endoscopy in there as well. And we've got some microbiology. Obviously, MiDOG next generation sequencing is sort of the more newer technology. And that way you can identify exactly what species is present in the infection. So maybe you think there's a bacterial infection, so you can identify that. There may also be secondary infections, may have a secondary fungal infection on top of that as well. And we've still got our cultures and then cytology. I like to run cytology in combination with my cultures, just so you can see there's actually sign of disease. You're not just picking up some flora or some bacteria that's not actually causing an infection. So you want to see signs of like an inflammatory response. And then we've got cytology. Not sure if Janina's managing to join us there. That would be amazing if she does. But I've just seen her window come up. And then we've got PCR, typically for viruses, but you can do mycoplasma with that as well. And then we've got histopathology as well. So if you're taking these biopsies of diseased lung tissue, then that's always nice to get some histopath images and a diagnosis that way as well. So just looking at some radiographs, typically with chelonians, you want to be taking 3 views: dorsal ventral, a craniocaudal, and a lateral. So here we've just got the craniocaudal and the lateral, just because this is more specifically for lung disease. And you can put your patient on a box or a cup like this. Probably a cup's actually better, just because the legs dangle down, so it actually increases the visibility of the lung fields there. But you can clearly see these lung fields are asymmetrical. We've got severe pathology going on here, and perhaps a little bit on his right-hand side as well. And we've got the lateral view as well. With lizards, I tend to do 2, or you should do 2 views. Same with snakes as well, 2 views. You can do your dorsal ventral. That's less useful for lung fields, but good for coelomic cavity. If you do your DV view for lung fields, probably some coelomic organs are going to get in the way, so make it less diagnostic. You also have to be careful with some species like bearded dragons. They have the spines on the skin, and that can look like pathology in the lung fields if you're unfamiliar with their anatomy. So I'm just going to see if I can make um, see if I can add Janina here.
Yeah, can you hear me?
Oh, welcome to the show, Janina. How are you?
Doing great, thank you. Great
Oh.
webinar so far.
We can't see you yet. Have you tried turning on your camera?
I have, but it says you didn't allow it, so don't worry about it. Just keep
Okay,
going.
we'll come to that. We've got your voice. That's the most important thing. So just continuing with this, we'll come back to Janina's slides momentarily. Um, So in terms of lateral view, what you can do with lizards is you can actually just tape their feet down. Lots of them just let you sit like that, let you position them like that, I should say. Um, I don't generally sedate them for this. Lots of them just sit there and look at you, so you don't really need a sedation. However, if you've got a very sprightly patient, then you may need to give slight sedation, bit of midazolam just to take the edge off things. But generally, if you pull the legs down gently, then you can just tape them and you get much better views of the lungs. Sometimes you can just put a towel or something over their head as well. That can stop them from moving around. Then we've got CT scan. I try and CT scan as many patients as I can over radiography just because you get that much better detail. Plus, you can see comorbidities as well. So sometimes it's not just the lungs you're looking at. Perhaps there's a lesion that's spread to the liver, and you're probably not going to pick that up with radiography. You can add in ultrasonography as well, or you can do a CT scan, which obviously does everything very, very detailed for us. And because of that, I do a pre and a post contrast CT. So we try and get a IV line in place with lizards. We tend to go for the ventral tail vein. With chelonians, you can go for the jugular vein. That works very, very nicely as well. Lots of times for the CT, I do sedate them just because it takes longer than just a quick press of a button for the X-rays. And you don't want the patient moving. That can obviously blur the images and make the whole diagnostic test undiagnostic. Then you need to start again. So I always do a little bit of sedation just to prevent any sort of movement. And also, you don't want them running off the table either because that's a complete disaster. So I usually give a bit of sedation for them. Now, in terms of CT images themselves, thank you, VetCT. This is who we use as our reporting service. And you can see, let's start with these lower images. You can see that these little nodules that you may or may not pick up with radiography, but then there's just some thickening that you wouldn't pick up with radiography. And then you can pick up comorbidities as well. Like I said, we've got a reproductive follicle down here. So if you just did X-rays, you probably wouldn't know that's down there unless there's some coexisting eggs as well, and then you scan and see some follicles. So that's why I'll do either CT or radiography and an ultrasound scan. You don't want to miss anything. And just to show the detail, we've got this patient up here, this tortoise, and you can see we've got some otitis here as well. You would never pick that with X-rays, again, unless you're seeing some bone damage going on. And then move my head out the way. And then we've got some rhinitis here as well. So again, you're not going to get that detail on a radiograph. So just touching on some endoscopy, I just wanted to show these two images side by side here, just because I wanted to show you that the larger the endoscope, the better the image. So the larger the scope, the more light that you can let through. With the smaller scope, it does become a little bit more fuzzy. So this is a 2.7 rigid endoscope. And you can fit these into most size chelonia. I've used it without the sheath. If you put the sheath on it, it does become probably a bit too large. So just be very, very careful you don't bend it because they do break quite easily and your boss is not going to be happy. And this is the 1.9. You can see there's a little bit of blood on this side as well. So perhaps that's something's coating the screen as well, or the lens as well, making it a little bit fuzzier. But I just wanted to show you the difference there. And then this is a patient on the right-hand side that I've done a ovarianectomy on, and I use the scope for my chelonians to do an an endoscope assisted ovarianectomy. And I've just taken some pictures. You can see this is some lung tissue here, and then I've got some hepatic lipidotic liver there as well. So with tracheoscopies, you're probably not going to be taking any biopsies or anything like that. If you do see some infection, you can inject a little bit of saline and suction that back out again. That might give you a good sample to test or do a microbiological test to try and find out what bacteria is present there. However, with tortoises, they've got a quite a short trachea, and then it quickly bifurcates into the bronchus or the bronchi. So you're probably not going to be able to get down to the lung tissue very well. Equally with snakes, they've got such a long trachea, unless you've got a really long endoscope. So that the thin flexibles might be your best option. You're probably not going to get all the way down into the lung tissue. So a option is a transcutaneous endoscopical approach, and that is where you anesthetize your patient, aseptically prepare the area, and you want to be targeting the middle part of the lung, which is the semisaccular part. The cranial part is where gas exchange takes place, and that's the vascular part of the lung. And then the caudal aspect is the saccular part, which is avascular, and it's thought to be used for buoyancy in aquatic snakes and just as a gas reserve in other snakes as well. So you want to be going for that junction in the middle, and that is roughly 35 to 40% of the, 35 to 45% of the snout to vent length. And what you do, you have your patient in lateral recumbency. Most snakes only have the right lung. However, boids have both, so you can go either side. And you want to be doing a craniocaudal incision between the second and third row of scales. And then you want to blunt dissect sort of through that coelomic muscle and the coelomic membrane. And then once you find your lung tissue, you can then use stay sutures to pull them out of the body cavity gently, and then insert your endoscope into the lung field that way. And you can direct the scope cranially, and you can obviously see the vascular cranial part of the lung. And then you can turn it around and pass the scope caudally, and then you can see the saccular part of the lung. And as it's so thin, you can see the coelomic organs through that thin membrane as well. And don't forget to take your microbiological samples as well. So sort of similarly for chelonians, you can do a transcutaneous approach. So you can, the least invasive way is do it transcutaneously through the prefemoral space. Again, you want the patient anesthetized, aseptically prepared, lateral recumbency, and then you do a craniocaudal incision at the craniodorsal region of the prefemoral space, just because obviously the lung field is going to be dorsal. And when you're through, you want to ask your nurse to provide a breath, so you have high tidal volume, and it's just going to push the lung tissue out, and that will allow you to use your stay sutures again, just to grasp the lung tissue. You can make your incision and insert your endoscope through the lung tissue that way. That gives you a much better evaluation of the lung. You actually can have quite a good look around, and again, take your samples that way as well. The final way in the chelonian species is a bit more invasive. Again, anesthetized, aseptically prepared ventral recumbency, and you want to be drilling through the carapace directly over the site of infection. So you want to be doing your ideally CT, just so you know exactly where the lesion is, and then you want to be using that to guide your incision. So just do an osteotomy site over the area of disease, and just for approximation, you want to be using a 5mm drill is in terms of diameter to fit your 2.7 and operating sheath down there. You're a little bit limited because you can't really sort of move the scope around. That's why you've got to be directly over the site of infection. And once you've drilled through, you want to be drilling through when they're on expiration, just so that the lung tissue isn't there. And then once you drill through, you can use some forceps, some thin forceps to perforate through the tissue. And then you put your endoscope in there. So another less invasive way to do this is to do a transtracheal or a lung wash. It's not called a bronchoalveolar lavage in reptiles just because they don't have alveolar. So you want to do a transtracheal or a lung wash. You can also do a nasal lavage. And this is very good at detecting mycoplasma in reptiles because this is where the epithelium the bacteria likes to attach to. So the point of doing this wash is to identify the underlying pathogen, obviously, and evidence of disease. So it goes back to doing your culture or your next generation sequencing, and then a culture on top of that as well. So we want to take that sample, and then you can do gram stain cytology, viral testing as well. So some specific viruses respond better to actual sampling from the lung tissue as well. So how I'll do that is, you want to sedate them or anesthetize them, depending on the patient, how deep that you need them to be. And then I would open the mouth with this tongue depressor, and then I would clean the area topically with some iodine or chlorhex, and then I would insert I generally use a urinary catheter or a red rubber catheter to obtain the sample. One issue of that is you can get some local flora on your sample just because you're putting it into the oral cavity despite cleaning it. So another option is you can put a red rubber catheter down first, and then you insert another tube within that. So the red rubber catheter will be sterile. You put your other tube down that, and then you're more likely going to get a more sterile sample. So that's one thing I tend to do these days. Um, and just to illustrate that, I've got this terrapin here, and you see I put my red rubber catheter down first. So you're clearly not going to be touching any oral mucosa with your cat urinary catheter, and then you take the sample that way. So I've just got a little short video just to show how I do it. This patient is completely anesthetized, and I've got them on their side just because from the radiographs we could see that the disease was unilateral. So if it's on the left side, you have left side down, and you're most likely going to enter the left bronchus if you have it that way. You may not, though, it's not guaranteed unless you put an endoscope down there, but that would be my suggestion. So let's just see how we do that. So my nurse is holding, and I've just used my finger to hold the mouth open. And you obviously want to be aiming down this glottis, which is where the red arrow is pointing. Don't forget to remove your stylet, just so it can breathe. And I'm going to use some warm saline. Again, the illustration there of the red rubber catheter. Now I'm just going to use some warm saline, 5 to 10 mils per kilo. And then I'm just going to slowly insert it into the lung field. And I'm just going to ask my nurse just to gently shake the patient, just because that helps to break down any sort of mucus and debris there, and it gives you a better sample. And I'm just going to suction that out. Don't expect to get it all back. You're probably going to get 20% of the fluid back, so don't panic if you only get a small amount. I'll then turn the patient upside down, and then you can sort of gently pat them, and then that can help excess fluid come out as well. There we go. And then similarly, in a bearded dragon, again, anesthetized. Sorry about my big head in a way. Again, I'm using like a tongue depressor or a contact applicator to insert the tube or the urinary catheter into the glottis and the trachea. And again, just gently irritate or agitate the body or the thorax, or coelom, I should say, in a reptile. There we go. And you don't want to take the catheter off and then insert it into the sample pot. You want to make sure what you've got in the catheter tip is incorporated into your sample as well, because that's probably where the most juicy part is. And then you want to turn them upside down again just to get rid of all that. So we've got our sample here. With snakes, much easier. They're just literally one long tube. So if you hold them upside down, then obviously all or a lot of the fluid is going to come back out again. Just make sure you don't send that sample away from the collecting bowl I've got there, because when you're holding them up and you're gently patting them to help remove some of the fluid, some skin cells, some skin bacteria, some oral flora is all going to go into that collecting pot. So only get what you've taken with your tube out. One thing I would say is in severe infections, you can repeat flush. So you're not just getting this as a diagnostic tool, you can use it as a therapeutic measure as well, because you'd be surprised how much gunk comes out of there. So it really does help them, especially snakes, I do find. So, so what are we going to do for sort of treatment and management? So initial stabilization, as always, we want to make sure in the correct temperature, so the preferred optimal temperature zone. And that's both in clinic and obviously when you send them home, you want to make sure their husbandry is correct at home. So we're going to put them in a setup vivarium. Usually these patients have been sick for a while, and it's only when they got really bad the owners noticed. So they're usually dehydrated, malnourished. So we want to give some fluid therapy as well. A couple of ways you could do that, ideally IV. However, initially, I don't think it's a problem just giving it subcutaneous or intracelomic. And then we don't know how painful these are for these patients. So I'd always give some analgesia. Morphine's my go-to in hospital. And then there's some debate whether we give oxygen. I generally say if the patient is open mouth breathing, then I'm going to give the patient some oxygen because it's telling me he needs more oxygen. So we can use a gas mask or a face mask, or you can just put it in an oxygen enclosure. But typically, if it's not open mouth breathing, it doesn't look dyspneic, then I'm not going to put it in oxygen. And then nutritional support. I don't think you need to jump in and start feeding it Emerade or whatever critical care formula feeding. I think let's stabilize it, rehydrate it, and then I'm sure feeding it the next day is not going to be a problem. I also don't think you need to jump in with antibiotics straight away as well. Again, I don't think it's going to be a problem waiting a few hours to run your diagnostic tests and then giving a more appropriate antibiotic. So big decision is always, do we send home? Do we keep it in hospital? If it's a severe infection, I would want to keep this patient in hospital so I can support it, give it pain or better pain relief that we can use at home. And we want to obviously make sure we do any husbandry correction. So if the owner's keeping it too cold, high stocking density, inappropriate humidity, then we want to make sure we correct that as well. And at home, we want to provide fluid therapy, nutritional support, and pain relief as well. Okay, you can use different drugs, but we still want to give some sort of treatment at home as well. We can either, for chelonians, place an O tube, which we do very, very frequently in chelonian species. Quick, simple procedure to do. You can do it under sedation with a local block is one thing I like to do in very, very sick patients. Or if they're more stable, you can do a full anesthetic. It's with everything, there's always that balance between the risk to the patient and the benefit to the patient. Or most lizards, we just syringe feed into the mouth. Geckos, I tend to just touch the side of the mouth and they like to open up for us. Just be super careful. A lot of sick patients do have metabolic bone disease, so you just want to be careful that they don't clamp down or bite down on the syringe because they can fracture their jaws. So more specifically for respiratory infections, obviously you want to be microbiome guided, so next generation sequencing or cultures. And then lots of people jump to obviously fluoroquinolones, third generation cephalosporins. However, probably more better first line would be maybe something like TMPS. And then once you've got your sensitivity results through, then you can be more guided by that. But don't just jump in for marbofloxacin or enrofloxacin straight away. Mycoplasma there has been some debate what the best antibiotic for mycoplasma is. Feel free to write in the chat or the Q&A why you think mycoplasma does not respond well to something like ceftazidime. That will be useful to see if people get that answer right, and I'll go through it at the end. But more recently, people think azithromycin or clarithromycin are better choices. Some sources still say tetracyclines are a good option as well, but previously we've just been using fluoroquinolones for that. And also I've put physical removal of material. That would be either nasal flushing if there's copious amounts of discharge there, or these lung washes to try and remove as much of that bacteria as possible. And then nebulization. You can nebulize them with just saline. That helps moisten mucous membranes and can help break down some infection or pus. I like to add F10 in there. That has nice antibacterial, antifungal properties to it. Other people use antibiotics. That's absolutely fine as well. I've used gentamicin in the past. That works quite nicely. Just one thing to point out is you shouldn't be using an antibiotic and mucolytic at the same time. So just bear that in mind. Choose one or the other. But I quite like F10. Again, we don't want to be using antibiotics if we don't need to. So generally, systemic antibiotics plus F10 nebulization is the choice I go for. And we've got intrapulmonic therapy, which is what I was saying about drilling through the tortoise carapace. And you can actually leave that hole open and then continue to apply like topical medications to that area of infection. And this is how I tend to nebulize. I just put my terrapin or patient in there, and I just attach the nebulizer. Typically with mammals, we leave them in there for 15, 20 minutes. With reptiles, they've obviously got a far lower respiration rate, so you can even leave them in there for an hour or longer. Just make sure they're not in a cold area or anything like that. You want the temperature to be suitable for that patient. So in terms of prognosis and considerations, obviously isolation is a big one. If you're keeping them in your hospital or if they're going home, they don't want to be around other animals because obviously you're going to have spread of bacteria that way. Like I mentioned, mycoplasma should be considered a positive, or they should be considered positive lifelong, even though clinical signs have resolved. And don't be surprised if there's a relapse later in life as well. And then prognostic factors, obviously length of disease, how long has it been sick for? Are there any other comorbidities? Is it dehydrated and malnourished? Those will obviously lead to a poorer prognosis. However, if the owner's really on the ball, husbandry's good, and they've detected the disease early, then probably the patient's got better prognosis there. So just going to touch on some viruses. Tortoise herpes virus is probably the main one that we do see in hospital. It is the most prevalent viral infection in chelonians. However, be aware it doesn't just affect chelonians, it affects most species, if not all species. But there's over 20 types of chelonian herpes virus. They don't just affect tortoises, they affect sea turtles, causing grey patch disease and some other diseases as well. But the most important one that we think about is Testudium herpes virus 3, which is the most widespread and pathogenic virus in tortoises. And they do present it with quite non-specific clinical signs as well as more specific. So you see the anorexia, lethargy, and then start seeing rhinitis, conjunctivitis, stomatitis. And you can see these disgusting oral plaques here. Very, very caseous, affects the whole oral cavity, and you can see it affects the tongue as well. When you're sampling, I'll tend to target these areas as well. One thing to mention is mycoplasma and herpes virus can be difficult to differentiate from each other without diagnostic testing. So that would be one thing I'd suggest, testing for both. Having said that, there can be you can get coexistence of herpes virus and mycoplasma, and you can even get that in combination with rhinovirus in chelonians as well. So, Janina, just a quick question. Obviously, just having an all-in-one test, hopefully, MiDOG next generation testing can detect all of these. Can you detect viruses at this stage as well as bacteria?
At this time, not yet. We're setting up a PCR panel for viral testing in the short term, but the plan is that by May, we should be testing for all DNA viruses and all bacteria and fungi and parasites within 24 hours. So we're in the last phases of the R&D. So hopefully we can offer that very soon.
Yeah, so that'd be absolutely amazing because at the moment we've got to run a specific PCR for this, a PCR for that, plus an aerobic culture. Do we need to run an anaerobic? Do we need to run a fungal culture? So this is a bit of a game changer where we just do one swab and we just find out all the pathogens on that sample. So that would be absolutely amazing for clinicians. And we also need to look at other tissues as well. So like I said, we don't just want to target what the owner sees or what you see in your clinical exam. There can be other tissues that's involved as well. So with herpes virus, we worry about gastrointestinal system, hepatic tissue as well, and can affect neurological and cutaneous tissues. So other viruses I said I'll mention as well. So even though herpes is herpes virus 3 in tortoises is a big one, we do see lots of viruses in snakes as well. So Felkler virus is probably the big one in terms of, especially in terms of respiratory disease. And you want to be sampling the oral and oral cavity and the cloaca, or you can do your tracheal wash. And then we've got arenavirus or inclusion body disease, now better termed reptorinavirus. And again, oral and cloacal swabs run for PCR or very soon MiDOG next generation testing or sequencing. And you can also do whole blood. So I would actually run them both together just to give you as good a chance of diagnosing the virus as possible, because you can see inclusion bodies within the red blood cells. And ideally some histopathology as well. So targeting the esophageal tonsils is a nice site because the virus likes to hide there, or getting a liver biopsy. But ideally you want the esophageal tonsillar biopsies. And then sunshine virus, again, another respiratory infection, mainly Australian pythons is what this affects. And again, you want your oral and cloacal swabs for this. Adenovirus, obviously another big one, mainly occurs in bearded dragons, water dragons, and snakes, which is where we tend to see it in clinical practice. However, lots of different species can get affected. But those are what we see in clinical practice a bit more. And again, oral and cloacal dry swabs to diagnose out on PCR. And in terms of treatment and management, again, as always, hospitalization versus home care. No matter what, keep them isolated. You don't want to be infecting the whole of your collection or whole of the owner's collection. You want to be letting them know how contagious some viruses can be. And in hospital, keep them isolated. You do not want to infect your hospital with these viruses as well. And then some ongoing supportive care. Lots of these are very, very sick. They become dehydrated very, very quickly. So you want to give them as good a chance of fighting the infection. So correct temperature zone, hydrate them, get nutritional support on board as well. And you can use some specific antiviral therapy. Acyclovir is probably the most researched and can be effective. I find it quite variable. You can use it systemically at 80 mg per kg 2 to 3 times a day. There's also a topical application. So if you've got a tortoise with herpes virus, you can apply it on the lesions inside the oral cavity and on the tongue. There are others out there. Valacyclovir is another one. You tend to get better bioavailability with this antiviral drug. And you've got some topicals as well. You can use F10 again to clean the mouth, flush the nose out as well, or 0.5% chlorhexidine solution as well. And then when they get these virus infections, it's not uncommon for them to get secondary bacterial or fungal infections on board as well. So test for these, and then if appropriate, give antibiotic therapy as well. Lots of people ask me, can we give vaccinations to reptiles against viral components, viral infections? At this stage, as far as I'm aware, in clinical practice, there's not. I think there's been studies into Felkler virus in snakes, and I think herpes viruses in tortoises. Maybe don't quote me on that, but I'm pretty sure it's Felkler virus and herpes virus, but I don't think there's been a successful vaccine. For zoological collections, West Nile virus, I think there's a vaccine for crocodilians for West Nile virus. And again, biosecurity, isolate, highly contagious. So very, very vital for breeders, snake breeders and shops as well. If they've come back as a positive for a virus, so Felkler virus or reptorinavirus, this can wipe out large numbers of their collection. So unfortunately, if they for the benefit of the collection, sometimes these patients are euthanized. So very, very important to find if these are positive, and if they've been kept with a breeder or a shop, you want to test ideally the whole collection, but definitely those around that patient as well, because otherwise you just can have spread throughout the whole collection. Usually long-term prognosis for these viruses are poor. Lots of them do not recover, and if they do, then there's a relapse in the future as well. And much like Mycoplasma, I'll treat these as long-term positive patients as well. So just moving on to abscesses. Just got a few slides on this. Abscesses, so localized areas of infection, very, very different to mammalian abscesses, which are quite liquidy. I'm sure there's a better word for it, but liquidy. And then abscesses in reptiles are more sort of caseous with a thick fibrous capsule there as well. So for that reason, we call them abscesses or fibruses. And here's just an example here. This is a post-mortem on a bearded dragon. You can see I've reflected the fat pads, the coelomic fat pads, and then this is the abscess here. And you can see how thick that capsule is, and the material inside is very fibrous indeed. There we go. Yeah, so these can be very, very difficult to treat. You need to physically go in and just surgically remove them. These can be caused by inappropriate husbandry, lowering their immune system, or maybe trauma, caused like an abrasion, and then lets bacteria in. And you can get hematological spread throughout the body, which is maybe what's happened with this patient here as well. You can get them anywhere. So unfortunately, this patient has lost its leg from memory. This one from ages ago. I think this was a rodent attack during hibernation, and then it's got juicy abscess there. Snake with upper respiratory abscess. And it's not uncommon for us to see these oral abscesses or ear abscesses in tortoises and terrapins, usually down to lack of vitamin A or poor husbandry or like unhygienic water. And we've got this sulcata. This one's anesthetized on its back, and we can see we've got a massive submandibular abscess here, which we surgically removed. And everyone loves some juicy abscess photos. So I've got these geckos. I see them quite frequently in geckos on their face. We've got one just behind the eye here, and this one we've actually got one behind its right eye, and then obviously under its jaw there as well. So you want to be sort of removing these, giving these a good flush through and a clean up, and obviously testing and antibiotic treatment as well. So as always, we want to treat the whole patient. So we want to do a CBC and a biochemistry. A blood culture might be useful with these patients just to make sure there's no spread of infection throughout the bloodstream as well. Then some imaging. Is it just superficial with what we can see, or is it spread to other areas of the body, the liver, for instance? So even though we've just got a superficial lump, we want to do some radiographs and an ultrasound or a CT just to see if there's any other disease going on. And then we want to be sampling this. I wouldn't just aspirate it. It's probably going to be non-diagnostic. What I'd generally do is I would open up surgically, scoop the whole lot out, and send it off for some testing. This patient here I actually thought was a tumor. So I sent off for histopath and culture, and it come back as it was a bacterial granuloma. So how do we treat these? Like I said, you want to be surgically removing the liquid part plus the capsule as well. Copious amount of flushing. I tend to use, again, just like F10 during the surgery just to have some additional antibacterial properties. Then you got the option to open it and close it. I wouldn't marsupialize it like I would in a rabbit, but I do like to leave them open or partially open just to allow drainage. You can flush it in hospital after the surgery, and owners can flush it at home as well with warm saline or iodine or F10 or whatever your preference is. And then obviously appropriate antibiotic therapy as well. If husbandry is not good at home, you want to make sure you got a better hotspot and a temperature gradient. These are just examples of what you may need to improve. Sometimes they lack vitamin A. This can cause these ear abscesses and these terrapins, so you can give injections of vitamin A. Just be careful you don't give it to herbivorous patients, just because that can actually cause hypervitaminosis A, so too much vitamin A, and you can see things like skin sloughing. So for terrapins, yes. For tortoises, no, basically. Are there any sort of abrasive surfaces in the enclosure or substrate that can cause a breakdown of the integument and allow microorganisms to enter the body? Or is there an aggressive cagey mate that likes to attack each other? And again, that can let bacteria in. And obviously, these abscesses can be painful, so we want to give analgesia, fluids if it's dehydrated, and nutritional support if required as well. So here's just an example of an ear abscess. You want to anesthetize these, and I used to just do like a small like crescent opening and pull the infection out. Now I just take the whole thing off, just because I find you can do a much better job. You clear out much more of the abscess, and I find it's less chance of recurrence as well. And I just leave these open. There'll be actually no skin to suture closed. It will just granulate and heal by itself. So I'd surgically remove these, send it off for a culture. So make sure you get a nice sample here. And like I said, leave it open. This allows drainage, like I've already mentioned, and flushing with saline, F10, iodine, whatever you prefer. And you can also instill some antiseptic ointment. Again, F10 Barrett ointment I've used in the past. I've not seen any toxicity or neurological signs of applying that into the ear. So I like to use a combination of all those, and also sort of antibiotics on top of that as well. So you can get these hemipene abscesses. I see these more frequently in geckos and other species. It can just be a small swelling like in this one, or I've actually not even made my incision here and it's actually ruptured through the skin. So I've just grasped some forceps and removed the scab, and also you can see all this is abscesses following it as well. I flushed it and then partially closed it and continued flushing, and it just closed within a few days. Obviously, antibiotics on top of it as well, and did really nicely. So again, prognosis and considerations. Always health status needs to come into effect, but also how invasive the nature of the disease is. Is it just like superficial tissue, like on the back of a bearded dragon, or is it infecting deeper tissues? Is it full thickness? Is it invading liver, lung tissue, that sort of thing? And is there systemic spread? Obviously, deeper tissues and systemic spread, much worse prognosis. But if it's superficial, chances are it's got a good prognosis. But I always warn owners there's always a risk of recurrence there. So moving on to infectious coelomitis, just going to touch on this because we do see this quite frequently. And again, you generally see non-clinical signs. It's non-specific signs like lethargy, anorexia, weakness, dehydration, poor body condition. So you obviously need to do a workup to find out exactly what's going on. Here we've got a bit of dragon, which looks exactly like it's coelomic fluid. I don't think there's any publications to support that, but in this patient, we have that. And like I said, we've got to do some take the whole patient into consideration, CBC and biochemistry as always, and then a blood culture. You can see this guy has got lots of erythematous skin on its ventrum here. That is an indicative sign of a septic patient or a septicemia. Not always, but highly likely. So I'd always do a blood culture in a patient like this. And then we've got as always, our imaging. We want to do some radiographs and ultrasonography or a CT scan for better imaging, and then some microbiology to find out what the underlying cause is. One thing I would always say is usually there's a source of something there, so like a nidus of infection. So this instance, we're going to just show the importance of doing a thorough investigation. So here's a tortoise. I think it was just showing non-specific signs, not eating, not moving around very much. And we did some x-rays, saw a bladder stone. So I thought, great, let's just go in surgically and remove that. But I didn't do any sort of ultrasound scan or CT. And then we went into the surgery, and you can see there's a large amount of coelomic fluid here. So I sampled that and sent it away to the lab. And then we can see we've got some intracellular bacteria here. We've got some extracellular bacteria. And then we've also got a mystery component as well. So 10 points to whoever can tell me what this mystery component in there as well. Put that into the chat or the Q&A, and let's see how many people get that right. So learning from my lesson, we want to always ultrasound scan our patients, whether it's a chelonian or a bearded dragon or even a snake as well. But this guy here, or this girl here, I should say, just palpated some coelomic nodules or grapes, and we can see we've got these follicles here, and we've also got a bit of free fluid. So like I said, there's usually a nidus of infection, and we actually said to the owner 6 months prior to this, I can feel some abnormalities in his her coelomic cavity. I think we should ultrasound the patient. They declined it and then came back 6 months later when it was sick, and then let us do the scan, and then it had a large amount of free fluid in its abdomen. So we had to obviously treat that patient specifically for that. This is a different patient to the ultrasound scan. But I just wanted to use this as an example of how we would do a celiocentesis. So generally sedate them and or anesthetize them. I wouldn't do this conscious. And you can use the ultrasound to guide your sample. And I generally attach the syringe onto a butterfly catheter with an appropriate size needle. And then once you've got this sample, you can send it away for fluid analysis so you can find out what components are there. Is it actually infectious or is it liver, heart disease? You can get more information from that. And also we've got our next generation sequencing, cytology and cultures as well. So this is back to the bearded dragon with the follicles. So whenever we've got coelomic fluid, if it's infectious, it can be surgical correction or it can be medical correction or medical management. So here, if we've got some follicles, they've probably been in there for at least 6 months going by my previous clinical exam. So we've always done some testing, blood testing and some x-rays and an ultrasound scan and the owner opted for surgery. So we went through and performed a bilateral ovariectomy. And then don't forget copious flushing of that abdomen or that coelomic cavity, just so you can make sure there's a minimal amount of infectious bacteria left over and then suction it out as well. And this, you can obviously sample this this fluid and then send it off for testing if you haven't already done it before the surgery. And I just want to point out, you can see these tissues getting darker here. Obviously, we've got these bright orange ones, which are more normal, but we've got these more necrotic tissues, and more specifically in this patient as well. Again, this is a prefemoral endoscopic assisted ovarianectomy in this terrapin. See normal tissue there, normal follicle, and we've got this dark necrotic tissue behind it, and you can see it in the slide in the image here. You can see these disgusting necrotic tissue follicles here. So definitely that's going to be causing a painful and inflammatory response in the coelomic cavity. So as always, hospital versus home care. If it's really, really sick, I'll keep it in hospital. Husbandry corrections, if there's a reason behind having these follicles or whatever the underlying disease is, and provide supportive care as necessary. And as always, length of disease, comorbidities, and health status have prognostic factors. However, lots of these have advanced disease by the time they get to you. So, for example, in the bearded dragon, we diagnosed it 6 months earlier. It only came back for treatment after 6 months when it was very, very sick. Luckily, that patient did very, very well. But there are some after 6 months of the disease where they don't do very well. So that can definitely be a large impact on the outcome. So touching on the final chapter of this webinar, we should say. We'll obviously go back to Janina's slides as well, but just wanted to briefly go through skin and shell disease because we see this very, very frequently in practice as well. Whether they're lumps and bumps, these could be abscesses or tumors, or whether we've got these skin lesions, which we want to sample. We definitely see quite a lot of skin disease and shell disease in clinical practice. And here's a perfect example. We've got this terrapin with lots of abnormal scutes on its carapace and also on its plastron as well. And you can see it's eating into the shell tissue. This is what is commonly referred to as shell rot. And when we approach these, again, it's not just superficial. It can be deeper tissues affected as well. They can be sick from this. So CT scan and radiographs and ultrasonography to try and identify if there's anything internal going on. And again, our microbiology testing as well. So Janina, just a quick question about this actually. Some vets ask me the best way to sample this tissue. Have you got any tips for sampling a tissue for next generation sequencing for these lesions?
Yeah, so I would recommend following the same procedure that you would do if you would send the sample to normal culture and sensitivity testing. So it is possible to just use a swab and scrub the area, but also punctures or other material is possible to be sent for next-gen sequencing. If you have a tissue sample or even scrapings from the shell, I would just recommend breaking the components into as small pieces as possible so everything is touched by the reagent to preserve the sample.
Yeah, perfect. Because that'd be brilliant. Because yeah, lots of vets ask me this because they don't want to take a biopsy of the shell because it's quite invasive. So if we can just take the top layer, that'd be great for diagnosis of these conditions because we do see them fairly frequently, and these are typically caused by again poor hygiene in or poor water hygiene with these aquatic and semi-aquatic species as well. And here's another example. This is a golden coin turtle, quite commonly kept in Hong Kong and China. It's supposed to bring prosperity and good fortune. However, this guy probably doesn't have good fortune because it was kept in poor conditions. You can see there's lesions in that plastron. And again, these are thought of as shell rot, where probably should be referred to as superficial cutaneous ulcerative disease. And there's a couple of pathogens that can cause this. In terms of bacteria, Cytobacter frundi is probably the number one that is a primary pathogen. However, you can get a number of secondary pathogens that can cause these diseases as well. And also it could be fungal components. So uh, Epidomyces testavorans is another one that is actually a fungal infection rather than bacteria. And here you can see some osteomyelitic changes of the carapace as well. So these can get very, very deep. It's not just superficial. So you can treat with superficial flushes and creams, but also don't forget systemic antibiotics or antifungals. So another big one that we see in lizards is yellow fungal disease or CANV. However, this should not be, or this is not the correct terminology these days. These are more older terms now, especially with next generation sequencing and other identification methods. We know there's actually multiple species of fungus that can cause this. So Nanisiopsis, Parananisiopsis, and Ophidiomyces, Ophidiocola are the sort of the three families that can cause these skin lesions. The top two being more lizard, and then the Ophidiomyces affecting more snake species. So I just wanted to point out that there, like I said, there's a huge number. Most of these do affect bearded dragons, which is what we see them in clinically quite a lot of the time. However, they can affect other species. This is what we only know about at the moment. I'm sure there's other species of Nanisiopsis and Parananisiopsis that affect other species as well. But give us time, and I'm sure we'll start to identify these as well. And just typically, they present anywhere on the body. I tend to find them present more on the ventrum, around their femoral paws. Another area that they tend to affect is around the face as well, but they can be affected anywhere on the body or anywhere on the skin. So that's one thing to look out for. And they can come in a variety of colors as well. So it's not just yellow; they can come in darker grays and darker blacks as well. So it's not just yellow that you see them in. So in terms of what we do about it, a couple of ways. You can do superficial swabs from the area. And I'm sure and I know you can send these off for next generation sequencing as well, or you can do full thickness biopsies. I tend to try and do both, just so you've got a better idea of what's going on. Downside of the biopsies, obviously you need an anesthetic, and actually prices a little bit more. So you've got that anesthetic risk, obviously pain to the animal, and obviously paying to the owner's bank balance as well. But you can get a good understanding of what's going on. So maybe start with some superficial swabs first. And if you've still not got the answer that you needed, then maybe a biopsy will be the next step. But I'll do these under complete anesthetic. Don't forget analgesia. Do a full thickness biopsy. Make sure you get the edge of the lesion, so between the actual lesion and the healthy tissue, just because that's where the pathogen tends to be a bit more visible. And you can do a punch biopsy, which is what I prefer, or you can do an incision with a scalpel blade. I wouldn't use monopolar just because you're damaging the margins there, but I quite like the punch biopsies. And then just to close, just got a simple single suture to close that tissue. And here's an example of what you see under histology, or with histology. You want to be looking for hyphae and conidia. Hyphae are these long strands. I've just tried to highlight it a little bit better with the red lines, just because it's a little bit blurry, unfortunately. And conidia are look a bit like inverted red blood cells with the color inverted the opposite way around. You can also pick up secondary infections and also signs of a disease response. So we're looking for inflammation, and here's a significant inflammatory response where we've got high amounts of inflammatory cells, and then we've got this brown granular pigment as well. And again, treatment and management, how to do corrections if they're too moist, the stocking density is too high, inappropriate temperatures. You can surgically debride these lesions as well, especially if they're sort of around the face. They can be sort of quite thick and crusty. Just try and debride as much of that as possible, so your therapy will be that much more effective. And then you can use, I tend to use a combination of systemic antifungal and also topical antifungal. So systemic wise, you can use terbinafine or voriconazole. Voriconazole tends to be a bit more expensive, but there's some better safety margins with voriconazole over something like itraconazole. So either one of these would be good, but just make sure you monitor for any sort of toxicity. So maybe do repeat blood series throughout the treatment just to make sure there's no signs of toxicity there. But just one case study I want to mention: 5 out of 7 bearded dragons that were given 5 mg per kg once daily for 4 weeks, they unfortunately died. So you can't generally, there is a toxicity risk here. And if there's any signs of bacterial involvement, obviously appropriate antibiotics should be given as well. I did mention some topical applications. So chlorhexidine or povidone iodine are good options, or you can apply sort of anti-fungal creams as well. One thing I want to mention is one of the benefits of being able to identify different species of fungus is because you can actually use temperature manipulation to help your treatment. It's difficult to tell how effective this is, but one example would be Naniziopsis gorii, which is probably the most prevalent that we see in clinical practice. Has more rapid growth at higher temperatures, so 35 to 40 rather than at 30. So do you perhaps lower the temperature a little bit to minimize the fungal growth? And equally opposite, Naniziopsis draconi grows better at lower temperatures. So if you know which species it is, you can change the temperature slightly. One issue of that is if you've got Naniziopsis draconi, that's not too much of a problem because you want to keep your bearded dragon at a higher temperature, which is great. However, with gorii, are you actually going to lower the temperature, which may impact its immunity? So it's just a balance. Probably more studies need to be going into this, but just one thing that I thought would be useful to share with people as well. And again, biosecurity and isolation. And just for clinicians as well, you should always be wearing your gloves whenever you're treating any reptile, in my opinion, any patient. So I always wear gloves. So that's one thing I should mention as well. And just make sure, again, they're isolated. The owner's not keeping it with other bearded dragons or whichever reptile it is. Husbandry is on point. And again, prognostic factors, length of disease, how widespread it is. Is it superficial, much like the abscesses? Is it just like superficial? But don't forget, these are typically systemic diseases. This is typically a systemic disease, these fungal infections. So it's not just what you see. They can enter the body as well. So it can spread to the liver, can spread to lung tissue. So I always give systemic medications, not just topical. So that's the end of my bit. So thank you everyone for joining us and getting to the end of this bit here. What I'll do, I'm going to go back to Janina's section. So just bear with me a second. I'll see if I can go to the very beginning again. I might have to just, can I do this a quick way?
Maybe this works. Can everyone see my screen?
So I'm pretty sure it's up on my screen now, Janina.
Okay.
I think you'll be free to go talk as you can, and I will just sort of click through for you.
Wonderful. Thank you, Dean. That was a great presentation too. I really feel like I learned a lot. Thank you everyone for joining us today too. And I'll keep this short. I know we've been over the hour already. Just to briefly introduce us, we are MiDOG Animal Diagnostics. We're bringing microbiome-based and next-gen sequencing-based analysis to veterinarians. And since this week also to Australia exclusively with Dean. So we're very excited about that. And as clinicians, you know, it's very challenging to diagnose some of these pathogens that are causing significant infections in these animals, including some of the pathogens that you can find on this slide, Mycoplasma, Nanisiopsis, some of the organisms that Dean had mentioned previously. And typically, clinicians have for years relied on culture testing to identify these different types of pathogens. And culture testing has a lot of advantages, but also many, many disadvantages. And it is, after all, a tool that was developed in the 1880s, so over 200 years ago, and it is really time for an update, at least as we would think. Culture testing uses these petri dishes and agar media to identify pathogens that are taken from your patients. They are now in a very different environment than what they used to be. So trying to grow them in this artificial laboratory setting, you're missing a lot of the pathogens that are simply unculturable. According to the AVMA, about a third of all culture tests that come sent in from veterinarians return with no growth. That is a significant number. If you go for UTIs, the number is even higher, up to 70%. So if you imagine you were selling a test to clinicians that, or to pet owners that are just 30% are going to fail, then it's quite devastating. Dean, if you don't mind going 2 slides ahead. One great benefit of culture, one more, please. Um, One benefit of culture testing is, of course, that you get the sensitivity levels. But again, you're testing these microbes in a very artificial setting of this petri dish, so it might not actually reflect exactly how the antibiotic will be working in your patient. The alternative is PCR testing, which has been around since the 1980s, and the benefit is it's molecular based. It's either based on the DNA or RNA of those microbes, so you can identify exactly who they are with a high degree of sensitivity and specificity. The issue is most PCR panels only have a limited panel, so you have to have somewhat of an educated guess of what you might be looking for in order to select an appropriate panel. And when it comes back all negative, you're back to the drawing board, you waste precious time for the patient and some money for the pet owner. It is absolutely possible to predict antimicrobial resistance patterns and which types of antibiotic will be effective and which will not be based on the genomic profile of these microbes. However, because PCR is so limited to a few panels, those panels often include only one or two DNA markers, when in reality there's hundreds and if not thousands. One tool that combines the benefits of both of those is next-gen DNA sequencing. Just like PCR, it's based on DNA, so it has a very high degree on sensitivity and specificity. You're no longer relying on the phenotype, on what these microbes might look like or how they might behave. You have the actual DNA evidence to know who they are, how many they are, and what type of antimicrobial resistances they might be carrying. You can look very broadly for all types of bacteria and fungi in one single sample, even if it's complex infections like biofilms or multifactorial infections, you will catch all of that in one setting. And with this DNA evidence, we now know that there is 10 to the 20 microbes on this planet Earth, so an unimaginably high number. On the average dog that might walk into your clinic, you will find 100,000 different microbes, and only 3% of those microbes can actually be cultured. Given 97% of them, not all of them are pathogenic, some are commensal, but you get the idea that we are missing a lot, and we're missing a lot of novel pathogens that we just simply haven't been able to grow in this little artificial setting of a petri dish. And at this point, we're looking at 65,000 different types of bacteria, 5,000 fungi, 27,000 viruses, and 700 protozoa that we can easily detect, test for, and determine whether or not they're pathogenic or commensal by using their DNA evidence. This always sounds a little too good to be true, so I just wanted to show a brief video here of what it actually looks like when we are processing your samples when they come to our laboratory. They come in our DNA preservation reagents, and we start removing some cell debris. We break all the cells open, we get rid of the cell debris, and then we use these Hamilton robots that do a lot of the sample preparation for us. It's very mesmerizing and fun to watch, and for us it means less cross-contamination, less hands-on time for any type of lab technicians, so less errors and faster processing time. This is what the sequencer look like. We take the DNA of all these different microbes, we add different primers and different probes, similar like what you would know from PCR testing, but we're doing it in massive, massive amplification. So millions of DNA reads are copied and multiplied from your samples in parallel, whether or not that's from bacterial, fungal, viral, or parasite origin. We can get all these different microbes by using this approach. And then at the end of the day, all this is A, T, C, and Gs. So by having the nucleotides being added in this manner, we can read those genomic sequences of literally all bacteria and all fungi because we target very conserved regions of the bacterial and fungal genomes. We align all these reads to the database and then generate a report that highlights pathogens, antimicrobial resistances, and then later on the commensals as well. You get cell counts, so it's quantitative. We test for 43 different antibacterial drugs and 8 antifungal drugs for any kind of sample. And we have always free consultation available for all these tests as well. As you might have understood from Dean's talk, we can test all different kinds of samples, all different types of animal species, and all different bacteria, aerobic, anaerobic, as well as fungi and antimicrobial resistances. Yeah, whether it's a nasal infection, skin infection, body fluid, GI tract, swabs of skin, ear, you name it. Sample collection is just as easy as it is by like using a culture swab. We provide you with these sterile swabs that you just use to sample the impacted area on your patient. By not using discomfort, you simply rub the infected area about 10 times and then break the swab off into the collection tube. If you're submitting samples like feces or body fluids, you can add those directly into the tube. You don't need to use the swab that we provide. And Dean, you ask about punctures and tissues. You would add those directly into the tube. And once it's mixed with that DNA preservation reagent, the sample does not need to be refrigerated. It can lie around for over a year. Not that you would want to wait so long, but you technically could. And you simply put it into the mailer and send it back to our laboratory. Once we receive the sample, it takes us currently about 48 hours to generate these reports. And we realize that we're the first kids on the block that are offering this type of diagnostic testing. So on the next slide here, you can see the journals that we have published our results in. They're all peer-reviewed and validated. And we have at this point about 25 different types of publications looking at different types of animal species from cats, dogs, bunnies, bearded dragons, and even pilot whales. This was just briefly one of our studies that we published in AJVR last year. We reached out to clinicians to just sample all different kinds of animal species and select one sample for NGS testing, one for traditional culture testing, and then we compared the results directly. Just like the AVMA had published previously, 15% of all those bacterial tests came back, no growth at all, nothing, versus 83% of all tests had then an additional result for NGS testing. We only had one sample that we were not able to recover any bacterial species from, and that was bone material. And then for the fungal test, the situation was even more drastic. 81% came back, no growth at all, versus NGS testing was actually able to identify those fungal pathogens. And on the next slide here, you can see what specific kind of pathogens culture testing missed. It was those slow-growing bacteria, strict and facultative anaerobic bacteria, which makes sense because they die in transit. It included Enterococcus, Salmonella, or Klebsiella. Slow-growing organisms because the petri dish is only so big. So if an E. coli that doubles every 20 minutes overtakes the real estate, then those slow-growing organisms may be missed. Then across the board, all gram-positive bacteria were significantly underrepresented and missed by culture testing. Then those rare and novel pathogens make sense again because they're not necessarily on the radar of the culture testing. And across the board, all fungi, including Nanisopsis, Malassezia, Candida, Aspergillus, so even some of the classics. All fungi were significantly missed by culture testing. So in the AVMA publication, we then concluded that NGS testing is indeed the best solution for the no-growth mystery, especially for these exotic patients. We have a growing team of experts. We're very excited that Dr. Krista Keller just joined our board very recently, and we're expanding our board further. We have Dr. Wayne Rosenkrantz from the Animal Dermatology Group and Dr. Lynn Rodriguez-Hoffman from Texas A&M. No, now she's at the University of Florida, who is a leading expert in microbiome and NGS analysis. And we're very excited to be working with such amazing clinicians. So at this time, with the MiDOG test, we can test for all aerobic and anaerobic bacteria, all fungi, because we use very conserved regions of their genome. So it literally is like looking for a human thumbprint. We all have one, but it's specific enough to identify individuals. So we use a similar approach to identify all these microbes. We test for 43 different antibacterial, 8 antifungal drugs, and currently our turnaround time is 48 hours. We will reduce it down in 3 to 4 months to 24 hours, and then we will also be testing for DNA viruses as well as parasites. All of our samples have free shipping, FedEx overnight, at least within the continental US. Australia, I will admit, will take a little bit longer thanks to shipping, but all of our samples have free veterinary consultation included as well. Yeah, and with that, I would really like to thank everyone for joining us today and learning a little bit more about MiDOG. Dean, again, great job.
Thank you very
And
much. And thank you, Nina, for that talk. That was absolutely amazing. I've always been describing your work as a bit of a game changer in the veterinary field, having all-in-one test and such a fast turnaround is going to be massively useful in private practice and zoological collections, aquariums throughout the world. So amazing. Thank you so much for bringing your work to Australia as well. So hope we can bring your diagnostic techniques to Australia and help our patients here as well. What I'll do, I'm just going to skip forward to back to a later slide. Just give me 2 seconds. So just going to wrap up the webinar. So once again, thank you for everyone for joining us today. If you do have, I've got some questions I'll go through in a second. If you do have any further questions that you don't want to ask today, or if you just go home and think of them later, please reach out to myself on info@exoticvetsupport.com. Or if you have any MiDOG animal diagnostic specific questions, I'm sure Janina will be happy to answer those questions at info@midogtest.com as well. And also check out our websites and our Instagram pages as well. One thing I also wanted to mention, if you're not already aware of the conference that Exotic Vet Support is hosting in March, there's tickets still available. MiDOG is a sponsor of the event as well, so we welcome you to join us in Melbourne. I'm speaking, and a few of my colleagues and friends are speaking as well. So Dr. Nikolai Di Girolamo is a good friend of mine, used to work in Hong Kong as well at the same hospital as me. We've got Dr. Charlie Pignon joining us and Dr. Isidora Sladakovic as well. And then Dr. Alex Rosenwax, who I know very well as well. So they're all very, very knowledgeable, enthusiastic speakers. So I'd love you to be able to join us in Melbourne. And there is the QR code on the screen as well, which will take you straight to the register page. And now open for questions. So I'll just go through what we've got so far. Please send some questions through if you have any. Oh, and I've got some answers to the questions that I asked as well. So, yes, Mycoplasma lacks the cell wall, so beta-lactams doesn't work. Absolutely correct. We've got quite a few of you saying exactly that. So, well done, everyone. Thank you. I've got some questions. I won't read out your names, don't worry. What do you like to use to anesthetize the patients for a transtracheal wash procedure? So it depends on the patient. I don't do a one anesthetic protocol or sedation protocol fits all. Depends on one bearded dragon to another bearded dragon could be different. Also, it's different from one snake to a bearded dragon or a terrapin. They're all going to be different plans or different doses as well. So typically, I would use morphine as a pain relief, and then I'll add in something like midazolam on top of that as well. Um, that will give you a light sedation in most species. A lot of the times, I like to add Alfax IM in on top of that as well. So I'd use something like 1 mg per kg Madaz IM, and I'd use something like 5 mg per kg of Alfax alone IM as well. So those together work quite nicely. But there's lots of different protocols out there. Everyone's got different thoughts. And like I said, if we've got a very lethargic bearded dragon, maybe I'll just use a midazolam and just see how he gets on. Or if I've got a very feisty or spry snake, I'll add in maybe some ketamine as well. It just depends on that patient. Um, so do you have any injectable versions of TMPS or just oral? I think there are injectable versions of TMPS. I don't have any in Australia. I'm not sure if we can get hold of any in Australia, but I just use oral TMPS. I do prefer to use injectables when I can with reptiles, but I don't think I can get injectable TMPS at this stage, but it is out there. Why don't you use antibiotics and mucolytics together in I assume that's in nebulizing. I actually can't remember off the top of my head why you shouldn't use it together, but I'll find out for you and get back to you. So I will send you an email to let you know what that answer is. Question for you, Janina. Someone's asked, can you use your next generation sequencing for RNA viruses as well?
So technically, it is possible to use NGS testing for RNA viruses, just not in our specific setup. So RNA viruses is just, it's a different type of sequencing that we would need to do. So at this time, we opted to do DNA viruses only. And that will actually allow us to cover every DNA virus. We will add a PCR panel for RNA viruses to accommodate for the missing RNA viruses.
Perfect. Thank you for that answer. Um, so yes, so so we have got an answer for spermatozoa in the Chelonian coelomic fluid. Yes, that's 100% correct. Well done for spotting that. Uh, And another one for you, Janina, is a positive MiDOG test for nanoziopsis on a clinically healthy animal, not showing any signs considered positive, and the pet will eventually become clinical. I've had referrals that had positive from other clinics, and they were told to euthanize, and we've been tracking the pets with no issues.
So from what we have seen, identifying a pathogen doesn't always warrant a treatment. It depends on the host immune system. It also depends significantly on the cell counts. So just finding 1 or 2 cells of a specific pathogen might not warrant a treatment, but if you find 100 million cells, then it could warrant a treatment. Where is that cutoff between 1 and 2 to 100 million? The answer, it depends. It depends on the animal species. It depends on the collection technique and the body location. NGS testing is just one more tool in your toolbox. It's not 100% perfect. It's always the clinician's discretion to use this tool together with other markers of health of the animal, the history, behavior, allergies, all the other things. So just using a test result isolated is very challenging, and I don't think that would be recommended for any other type of test either. it's one more tool in your toolbox, but of course you have to put on your thinking cap and really interpret, what does this mean for my patient? How was the sample collected? What are the circumstances that the patient was under, and etc. And we would always offer free consultations for those cases where you can walk through the results with a veterinarian and go from there. So even for us, just looking at one report, we would never make any treatment recommendation because we just don't know the history of the patient. We don't know what else is going on, what other treatments have been done, what has not been done, etc.
Perfect. Thank you for that, Janina. Another question, have you used F10 cream as well as a fungal cream? I use one or the other. I quite like F10 quite a lot. So yes, I use F10, the barrier ointment, and I use that alongside systemic antifungals as well. Um, One for you, Janina. Has there been research to support the use of MiDOG samples in L form suspects?
In what kind of suspects, please?
The L form. I'm not sure what they mean either, unfortunately.
Well, I guess then the answer would no, because I'm not quite sure what it means
It's
either.
not sure.
It is a second language for me, so maybe whoever asked that could elaborate.
Yes, I'm not sure what they mean in that one either. Um, yes, so there's another question. So we can send fecal samples to my dog, just making sure I heard right. Yes, absolutely, you can send fecal samples. Oh, I've got a long question here. Okay, let me just read this for you, Janina. Uh, Antibiotic resistance is one of the most dangerous threats we are facing right now as veterinarians. Next generation sequencing is a great technique and it can support us as clinicians to identify different microorganisms. However, this technique is not used to identify antimicrobial susceptibility. In the MiDOG reports we received, the antimicrobial resistance tables where you show us which resistance genes are found in the sample, but some antibiotics are colored green. What does this mean? It is important to explain this since some people believe that you are recommending the use of that antibiotic, but since you do not evaluate antibiotic susceptibility, this cannot be the case. Could you please explain this? Did you
So
did you get all of that? It's quite a big question for you.
yeah, no worries. So we use different markers for antimicrobial resistances. So we have three different markers that go into our report that would then say not recommended, meaning resistant. The first one is intrinsic resistances, which are very easy to determine based on databases. For example, an antibiotic targets a cell wall. The pathogen doesn't have a cell wall. It won't work. So that is the first marker. The second is we're looking for specific antimicrobial resistance genes. At this time, we're targeting about 150 in about 4 months. When we're switching our sequencing process, we will do whole genome sequencing and therefore can actually detect every known genetic mechanism of antimicrobial resistances. So by finding these specific genes, you are using the genotype to predict a phenotype, meaning if a bacterium has the potential to break down an antibiotic, for example, by creating an enzyme, then it is very likely that this antibiotic will not work on the pathogen because the pathogen will produce the enzyme to break down the antibiotic. We're not growing any of these organisms, so we're exclusively looking at their genome to predict whether or not an antibiotic will work. There is a huge body of literature that has been studying this. Again, mostly in human medicine, because there's typically more funding there, where they would have isolates, even of Staph aureus, hundreds and hundreds of isolates that then they would grow in the laboratory for MICs and also do the DNA sequencing and see whether or not these results align. And in most of the cases, they do very, very well, over 99% accuracy. We are also looking at the entire microbial community. So let's say there's 100 cells that are causing an infection and only one or two cells are carrying currently an antimicrobial resistance gene. So we would then detect it in the sample versus when you send for culturing, they would not grow all 100 colony forming units. It's just not feasible. They would collect maybe one, two, or three colonies, depending on how efficient they would be working. But most likely they would then not detect the resistance because it's just in such a small subunit of the microbial community. But what then can happen is that the antimicrobial resistance just from these one or two members that had the resistance gene can spread across the microbial population, or those two could be the survivors, and then 2 to 3 weeks later, there is a recurrent infection. Again, it's not 100% a perfect tool. We are here relying on known markers of antimicrobial resistances. There have been decades of research being put into it, and it's a growing body of literature that's constantly adding new findings. But again, when we're comparing this to culture testing, these organisms were not growing in the first place, or we're having this artificial setting of a petri dish that is quite different than what it was on your patient. I'm not saying that NGS testing is 100% accurate all the time for these resistance predictions because we simply don't know everything. But in my humble opinion, it is a significantly better improvement compared to culture testing, compared to what we had to rely on historically.
Perfect, Janina. Perfect answer. Thank you for that. And I'm sure with time, your technology will get more and more accurate as well. I mean, it's pretty good at the moment, but I'm sure a few years' time there will be it'll be even closer.
Yeah,
Uh,
thank you, Dean. I think there was one more part about the good. The good that we were recommending this. So if you look closely at the description of our table, NR, the ones in red, are the only ones where we say resistance detected. We do not recommend using this specific drug. All the other ones, the white, NRD, and the good, fair, and poor performance, those were all cases where we did not find any resistances. But we did want to provide the clinicians with more information if there is known data about these antibiotics. It's kind of similar to the Target app. So you're using antibiogram data of published peer-reviewed papers that are looking this specific pathogen, this specific drug, on average, how well does this drug work? There are organisms that have been well studied, like E. coli or Pseudomonas aeruginosa, where we can add a lot of this good, fair, and poor performance. And then there's other pathogens that are either novel or really not growing well in the lab, where there's simply no data available. So the person who asked the question, I'm happy to explain that in more detail, but please take a look closely at the abbreviation keys that we add to our reports to explain what we mean by the different colors.
Perfect, thank you. I'm sure they can just contact you on your email address if they need further clarification, because it's yeah, quite an important topic and quite a long question to try and answer on a webinar as well. But yeah, so feel free to contact Janina on her email address as well. Another question, can this testing be done on non-human primate samples? Is that right, Janina?
Yes.
Yes, I believe it can be done on any animal. So yes, non-human primates, absolutely. Does MiDOG plan to offer shipping samples from Europe in the future?
Yes, we do. We do have a partner lab in Germany that helps us just with logistics of sending the samples because our DNA preservation reagent allows the samples to be sitting around at ambient temperature for over a year. We don't have to worry about the shipment time or temperatures. So no ice, no refrigeration, none of that is needed. It just takes 2 to 3 days longer. But technically, yes, I'm happy to get that sorted out for the person who's asking.
Perfect. And I've got a question. If you don't have Alfaxlo, what would you use? I assume that's for the transtracheal washes. I like to add in some ketamine. So midazolam ketamine works quite nicely in lizard species. You can also, there's other options out there as well. So medetomidine is also a good one to use as well. But for a bearded dragon that I need to do a transtracheal wash on, 1 mg per kg of midazolam, and you can add in 5 to 10 mg per kg of ketamine as well, IM. That equally works nicely. My preference is just alfaxolone, but whatever you prefer to use. The benefit of medetomidine is you can obviously reverse that as you can with the midazolam. However, you can't reverse alfax or ketamine. So yeah, a few pros and cons for each of those. So I've got another question. For your radiographs of the beardy, when it is taped to the box, how do you obtain the lateral image in a fixed radiograph table? You just have a movable arm. Absolutely. So yes, so I would have the arm where you can come down and do a lateral projection. Sorry, I should have mentioned that. If you have the beardy in lateral and have the beam from above, it's still possible, but it's not going to be as diagnostic just because of the movement of the stomach organs. I believe Christoph Mann did a very good paper on that. I can't remember what year it was, but it's quite a recent one. But yeah, ideally you want to have the arm come down and do a lateral beam that way. Just make sure your room is lead lined because you don't want to be irradiating the person next door. And I've got another one. Hi, Dean. Do you just close the muscle skin for the transcutaneous endoscopic procedure, or is the closure of the lung tissue as well? You want to be closing the lung. Typically, you can just pull your stay sutures up and just do a circular ligature around it, just because if you're putting more holes into the lung tissue, more chance of traumatizing the lung further. So you can just do a circumferential ligature around it, because otherwise you're going to get a pneumocelium, which is not what you want to be doing. Sorry, getting more questions coming through as we speak. What concentration of F10 do you use for nebulizing? I use 1 in 250. And can you please send a link to the quiz? Yes, just a reminder to everyone, when you exit out of this, you should get the quiz, and also you should get a follow-up email. So if it doesn't come up, you'll get an email with the link to the quiz as well. Perfect. I think that is everything. So once again, thank you everyone for joining us today. And massive thank you to Janina as well for joining us and going through her technology as well. It's going to be a massive breakthrough for all our diagnostic samples in the States, Europe, and now Australia as well. So looking forward for working with you. And if anyone has further questions, please just send us an email through. All right. Thank you, everyone. Take care.